Hello, everyone. My name is Michel, and I wanted to extend a warm welcome to all of you. Thank you for joining us today. We recently hosted 2 webinars on Mucuna pruriens, a tropical legume rich in levodopa. The first webinar was with Dr. Roberto Cilia and focused on the use of Mucuna in low-income countries where levodopa is often unavailable or unaffordable. The second webinar was with Dr. Rafael Maldonado and took a broader perspective. Now, due to continued interest and questions on Mucuna, we organized today's session with Dr. Tanya Denne. Since 2010, Dr. Denne has researched Mucuna for its potential in treating Parkinson's. And having been mentored by Dr. Laurie Mischley, she chose her Naturopathic Medical School with a focus on serving the Parkinson's community. Dr. Denne treats the whole person with a personalized, holistic approach and specializes in optimizing care plans and addressing treatment gaps. Driven by her passion for public health, she joined Dr. Roberto Cilia in Ghana a couple of months ago in February to help tackle Parkinson's care in countries where Mucuna is sometimes all they have. But before we dive in, I want to remind everyone that this session is intended for informational and educational purposes only. If you are seeking medical advice, please consult a healthcare professional. And for those who are new to us, No Silver Bullet is managed by Mark Lambert and myself with the goal of sharing valuable Parkinson's expertise. Our mission is to empower you with knowledge and motivation to make informed choices about adapting your lifestyle in order to manage your symptoms and hopefully slow down disease progression. We also share the recordings of our webinars on YouTube and Spotify, and you can find the details on our website, nosilverbullet4pd.com, nosilverbullet4pd.com. But now let's return to today's topic and welcome Dr. Denne to answer your remaining questions on Mucuna. Tanya, the stage is yours.
And hi, welcome. And I want to say thank you first to No Silver Bullet and PD Buddy for this opportunity to discuss a topic with you that I'm very passionate about, and to thank your wonderful organization for all the educational advocacy work your team does to benefit the Parkinson's community. So you all inspire me, and this is what fuels me to dive deeper into these topics. And so today we will be discussing the clinical use of Mucuna pruriens and how it's used in the management of Parkinson's. So Mucuna is a subtropical legume. It grows around the world. It has the highest source of levodopa, which is the precursor to dopamine of any plant that we've discovered now to date. Mucuna has a 3,000-year plus history of being used in documented Ayurvedic texts for Campavada, which was described in similar diagnosis as a shaking palsy in ancient texts. So here's the blueprint for today's presentation. These are the top 10 questions that we discussed for the clinical use in Mucuna that keep coming up. So if you want to rewatch or skip ahead to topics that are of interest to you. And thank you, I want to just reiterate, this is not intended as medical advice. Please follow up with your providers for individual assessment and protocols. And I also recommend that patients use levodopa-carbidopa as first-line medication in Parkinson's management, as it is also safe and effective. So my research work with Mucuna started in 2010 at Oregon Health and Science University. I was working with neurologists at the time at the hospital, and they were concerned that their patients were ordering Mucuna off the internet, and rightfully so. They're concerned that their patients were getting too much levodopa in addition to their prescribed Sinemet. So I conducted lab extractions through HPLC to test the quality claims of these products. And unfortunately, the Mucuna products contained between 6 and 143% of label claims. And no product was within the 10% of the pharmacopoeia limits, which we consider industry safety standards. So I saw this as a really big problem. It's what fueled my passion for this quality control research and for advocating the botanical safety among the Parkinson's community. So this research continues to this day. The middle picture is a poster presentation at the most recent Movement Disorder Society conference in Philadelphia in 2024. And this poster is a case study using Mucuna with a patient concomitantly with traditional levodopa, carbidopa medication, and seeing improvement from a combined therapy. So this slide is actually, we're talking about demonstrating the power of persistence and the power of collaboration. So working together for public health implications in Parkinson's at a global perspective. This research collaboration started when I was in medical school in Seattle, and the paper on the right-hand side was published during my residency here in California. And I actually got to meet Dr. Roberto Cilia in person at the most recent Movement Disorder Conference, and we planned our trip to collaborate in Ghana. We just got back in February. It was a fantastic trip researching Mucuna for the continued public health efforts. So this research journey started during undergrad through medical school. In my free time, I'd spend my Thanksgiving breaks in the basement studying Mucuna and this plant, not just in Parkinson's, but in antimicrobial studies such as the E. coli and MCF7 breast cancer cell line. So this plant has an array of very interesting chemicals and a very potent phytoconstituent profile. Mucuna has compounds that have yet to be discovered and identified that may actually potentially be helping with the anti-Parkinson's benefits that patients see as part of their treatment plan. So I think it's important because this highlights that Mucuna has antioxidant capabilities, cytotoxicity. Mucuna modulates inflammation and it neutralizes free radicals. And these are all thought to be problems contributors to Parkinson's disease. So many patients I work with have reported the reason they use Mucuna is because they see a quicker on time and relief of their symptoms. So this is used, so what are the potential benefits would be to extend or bridge the gaps between a Sinemet dose when they're experiencing the wearing off phase. There are studies, granted the sample sizes are small, demonstrating Mucuna's non-inferiority to levodopa carbidopa and a lack of dyskinesia with long-term use. So we're also planning follow-up studies in clinical trials, and we love to increase these sample sizes with international interest. So please email me if you're interested. Unfortunately, we do know that Parkinson's can have etiology sometimes from environmental exposure. And sadly, we're still using paraquat here in the US. And the rate of paraquat use has doubled in the past 5 years here in California. So we know that paraquat is being in the disorder in the world. So Mucuna may be beneficial for Parkinson's cases and where the phenotype is more exposure-based. Mucuna has these potential advantages because it has over synthetic levodopa, because Mucuna has multiple components of the electron transport chain, such as CoQ10, NADH. And these are components of the electron transport chain, and they're used in shuttling of energy in molecules. So here is our follow-up study in mice using the Mucuna extract that I made in lab. So even with 80% loss of tyrosine hydroxylase, which is actually the rate-limiting enzyme of conversion from levodopa to dopamine in the brain, and we used an MPT model, so we're inducing Parkinson's in mice, unfortunately. Mucuna resulted in recovery of several measures of gait and function. So the motor recovery was actually independent of the Niagara striatal restoration in the bottom right, suggesting that potentially other neurotransmitter systems or brain regions might be involved, such as the motor cortex or the cerebellum, and that this is why Mucuna might be having different mechanisms of action. So Mucuna might be less likely to trigger dyskinesia than synthetic levodopa, because mucuna, among many constituents, contains glutamine. So glutamine converts to glutamate, and glutamate converts to GABA. And GABA is one of our inhibitory neurotransmitters. GABA is actually what prevents us from acting out our dreams at night. And this may be why some people report improved sleep using Mucuna. I actually have a patient who has seen significant improvements in sleep with using just one capsule at bedtime after her levodopa carbidopa medication. Right before bed, she takes one capsule of Mucuna and has reported a 2-hour-long phase of sleep and without the significant leg cramping that she's been experiencing for years. So GABA is also an interneuron, which means it helps shuttle dopamine and serotonin across the synapse. Interestingly enough, Mucuna also has the precursor 5-HTP to serotonin in it in small amounts. So we also know that, unfortunately, serotonin is also deficient in Parkinson's patients. So this might be some novel mechanism of action for dopamine transmission that may be adding to some of the Mucuna benefits we see here for symptom relief. And research has shown that the oxidative stress inhibits the synthesis of dopamine, and free radicals act on the lipid membranes of the synaptic vesicles, which decreases the neuronal transmission in the synaptic cleft of dopamine. So Mucuna, being high in an antioxidant, can combat this oxidative stress potentially as it's full of antioxidants. So this might be one mechanism of action that is allowing it to be demonstrating these positive results. So I discuss Mucuna with patients often when they approach me about it. Sometimes I'll recommend it as an adjuvant if patients are having a wearing off phase. I recommend that patients use levodopa carbidopa first line as it's safe and effective, controlled, and the efficacy. However, patients often reach out because they're opposed to traditional medication, and so they're unmedicated. And I also have concerns about that. I stress that we need dopamine in a Parkinson's diagnosis. It's the gas or the fuel in the tank that is unfortunately empty in a Parkinson's diagnosis. So patients might be having an adverse reaction to levodopa carbidopa. That's why they reach out. They might be experiencing these off times in the phasing of bridging this gap between Sinemet doses. And our goal here is to smooth the dopamine curve. So we use Mucuna as a nighttime dose or pre-workout. And then sometimes in the phenotype of environmental exposure, if we can identify that, where we're targeting the oxidative damage and the mitochondrial support, where these are all examples where I would use Mucuna. So what are some of the downsides or risks of Mucuna? So contamination, for sure. We touched on regarding the QA/QC, so quality analysis, quality control claims. Contamination concerns, too. So there was a previous product that I was recommending, and at the time, it didn't have the full label disclosed, and I didn't even know that until recently when the label actually had all of the ingredients listed, and it contained saccharin as a flavored base. And this is problematic because we know that saccharin is a potential neurotoxin. So I have major issues with this. Another issue is that patients will be using Mucuna in secrecy as they don't feel comfortable or supported talking to their neurologist, and they don't have any guidance on using Mucuna. So there are brands that I recommend. The product on the top right, which is the Protocol for Life Balance brand. I have not tested these companies or anything recently since 2010 that's on the market. However, I do have a lot of patients that see benefit from this Protocol from Life Balance. Another brand would be the Now brand. They're the same company. They just have different ones, a physician line. But those are accessible. I actually linked them on my website, so you can purchase if you want to have access to those. I'm also growing organic small batch Mucuna now after 15 years of being concerned with what other companies are doing. So my contact information is listed. So we have our first prototypes coming out. And some brands of Mucuna advertise these very high levels of levodopa. So I have concerns here because I don't recommend this. I recommend patients actually avoid these high percentage claims for Mucuna. This is essentially like doping the levodopa. You should just take Cinemet then. It would be safer. Because I think that this is a phytochemical problem, because when you're trying to achieve this from a chemistry standpoint, you're then removing some of these potential symbiotic constituents that might be helpful in Parkinson's that are going to be lost in this approach. So to me, it seems more like a marketing scheme, like some is good, more is better, but this isn't the case. We really are going for this diverse array of phytoconstituents here. So the max percentage I recommend is about 15%. And that was like the product that I've been using with patients in the protocol for life balance. In nature, the extracts I've tested from various seeds around the world have about 4 to 12% levodopa. And this is what I formulated in the extract that we tested in the murine model with good results in mice. So this is kind of what I aim for. And so what about carbidopa? So carbidopa is allowing for the better absorption of levodopa, allowing it to cross the blood-brain barrier. I do recommend that patients take Mucuna with carbidopa. The availability of carbidopa varies. So here in the US, the minimum prescription we have is a 25 milligram dose. However, it can be costly. There are options though. There's this online pharmacy that you can take your prescription to and have discounted pharmacies online. Mostly I have patients that use Mucuna alternatively between doses of levodopa carbidopa, and this actually extends the half-life of the levodopa to carbidopa ratio, so you can use that chemistry hack to then use Mucuna in between doses, where you're not necessarily needing more carbidopa at that time. You actually just need more levodopa. So patients use this method like at bedtime or before a big workout. The goal here in Parkinson's dopamine management is keeping this steady state. However, we know the daily demands of life can be different. So I recommend people can use Mucuna PRN, which means as needed basis. It can be beneficial for some people. And I recommend that people use this 25 milligram dose of carbidopa, so 1 tablet to 1 capsule Mucuna, or a half, even starting with a half. And you can increase the Mucuna to 2 capsules if needed. So Cinemet's at 25 to 100, and this actually kind of equates to this. We want to keep this ratio about the same. So some people combine Mucuna with their synthetic levodopa using Mucuna in combination. Do I support this practice? Not typically, unless patients are under-medicated. So we don't want too much levodopa to flood the system. We really are going to keep trying to keep dopamine at this steady state, because otherwise it can cause this dyskinesia. So we want to focus on the dopamine curve and where the goal being steady state and less fluctuations, and not having dopamine take off like a rocket if you're double essentially dosing, contributing to these negative side effects. So I do have a few patients that do this though. They use the Mucuna at the same time when they're going to go work out though, which makes sense because they're about to have a higher energetic demand and the need for medication might be higher. I also see people that are doing this, they tend to be on the under-medicated spectrum. So ideally, I like to see Mucuna being used as a bridge for this off time and preventing these wearing off phases. Again, the goal here is to smooth this transition until the next dose of Cinemet is the best, what I've seen in practice. So often neurologists tell patients to take their levodopa carbidopa 30 minutes before a large protein meal, and then to wait 2 hours after a protein meal to take their meds. Would this technically, yes, be true for Mucuna? However, I see people doing it throughout the day and whenever. Protein is a really important part of Parkinson's diet, and we want to prevent sarcopenia, which is muscle wasting. So some tips here would be trying to eat your largest protein meal at the end of the day, where you don't need your medications necessarily to help you as efficiently like throughout the day. Plant proteins also seem to be easier to digest than animal proteins for some people. So we're focusing on things like avocados, nuts, walnuts, chia seeds, things like that. Interestingly enough, Mucuna contains about 20% crude protein itself. It's a nutrient-dense bean. So Mucuna has a nearly complete amino acid profile. It contains all 3 branched chain amino acids, which is really rare in nature for a plant to be this biochemically diverse and rich. So it's helpful for building muscle, actually. And this is why Mucuna is gaining popularity in some of the bodybuilding supplements. Mucuna also contains glutathione, so do avocados, which is a major constituent often for antioxidant effects that we use in Parkinson's protocols. This is especially important because we talked earlier about the etiology of environmental toxicity, and glutathione is a helpful form for detox and supporting the antioxidant load of the body. So I see it safe to be used with patients also that have undergone DBS surgery. I actually had a patient this morning email me about wanting to reorder Mucuna because it was working so well for her. She uses it in alternative dosing when she's having this wearing off phase. And she notes it has a quicker on time of action for her. So she likes it because she can rely on it more as an as needed when she's having these wearing off phases. And she notes her Mucuna lasts her about 45 minutes. And her Parkinson's meds, for comparison, last her 2 hours. So that's on the shorter spectrum. So how can we identify doctors that can help? So hopefully finding a neurologist that is integrative friendly or open to discussion. If you can, traveling to find one that is, that's a financial option. I do work internationally consulting or in person in Southern California. And we have a YouTube video up of our 3-month ethnobotanical research in India. Please find trusted providers and always let your neurologist know your total dopamine medication load. And thank you for your time. Please reach out if you have any questions, and my contact information is listed. I'm happy to work with you and discuss any lingering questions that you may have.
Well, Tanya, thank you so much for this fascinating presentation. I think you have really touched on a group of around 10 or 11 questions that had remained relatively unanswered during the previous 2 presentations. So I hope our community will be appreciative of your commitment to help them fill in those gaps. And also a question that many people have is that because we say you should seek medical advice, and people say, yes, but I don't know who to turn to. Well, clearly you're not the only person, but you're definitely a person who has 15 years experience in this product and a passion for Parkinson's disease. And your contact details are there for anyone who wishes to contact you. So thank you so much for this. I really appreciate your time today. And thanks a lot.
Thank you. You as well.